Laboratory studies, slightly we have already discussed. The test we will do normally, and complete blood count, neutropenia, uh, low WBC count. Many times in viral fevers, we see low WBC count, or severely immunocompromised patients, we see low WBC counts. And these days in COVID, many patients had TLC higher because of the steroid therapy. So it is important to understand that many times, even if you give short duration of steroid, it may lead to rise in leukocytes, WBC or TLC. So always be mindful of such possibilities. Burn and creatinine is important for kidney function test. And uh, liver, of course, many times the liver abscesses will present with some infective hepatitis, or even with jaundice or some other cause. History of alcohol is very important, because these are the people. History of mental health is very important, for these are the people who have poor hygiene, or who have poor self care. So amylase is important from pancreatitis, urine for the urine infection, and pregnancy test for childbearing age is important, because pregnancy in itself is a hyperdynamic situation. Patient may fever, complain, experience higher degree of warmness, kind of thing. So other things are blood culture, urine culture, sputum evaluation if you are doubting. Uh, so all these things we see in our practice, and I'm sure many of you would have experience and would be doing. But this discussion is only to revise this, the basic definitions, and how do we approach it, and share our own experience, because the practical experience is different from what we see in books. Because in books, if you read differential diagnosis, there are 20s of differential diagnosis, and it does not tell what could be the commonest possibility, what could be the commonest scenario in your patient situation. So it is very important to share practical experience, even in your own locality, with other practitioners. Throat culture I would rarely do, but urine culture is something which I do routinely. Sputum uh, also I do routinely. Blood cultures, in my practice, it's not required very routinely. Throat culture, it's not done routinely. A couple of patients I have done culture for pus or abscesses which were not healing, superficial skin, and it was very, very useful to get culture report those cases. And when you have CSF examination related problems, you are expecting meningitis, uh, or something related to brain infection, then it is always advisable to refer the patient or hospitalize the patient. And body fluid analysis may have pleural effusion or ascitic fluid, and this may require tapping as well as, and in my understanding, all these patients should be referred to specialized care, and not should be done at your clinic. Better for safety of the patient as well as for your own routine practice, because this is not what we see in routinely, and it is always better to get the patient, the most appropriate patient, and then it is a requirement many times that patient be hospitalized for and be investigated properly. Stool culture I routinely do not do. I would do routine culture. Radiographs, of course, many patients would require it, and at times it can give you diagnosis of tuberculosis or pneumonia or abscess. Abdominal X-ray mostly I would not do for evaluation of fever. More useful in common day-to-day practices, ultrasound. Other studies, as I said, these days, if we really cannot find and patient is not, then CT scan, ultrasound, and at times bone marrow and routine bone malignancies and all can be evaluated from bone marrow. Uh, Liver biopsy is not routinely, but if there is abscess, then probably you may need to do uh, abscess drainage or give a proper antibiotic coverage. PET scan is also recommended. Rarely, never ask any patient to do a PET scan for routine fever evaluation, and mostly these are done at hospital facilities or patients who have, really. Abdominal ultrasound is, of course, very, very important. And treatment, uh, we do from uh, the potential causes of fever, infections, viral. We have to maintain hydration and treat fever symptomatically for dengue, for example. Even for COVID, everybody knows the treatment that we have to maintain inflammation and inflammation. At times, patients may require steroids and all. And for infective things like enteric fever, and UTI, proper antibiotic treatment should be given. And if you empirically, most of the times I use cefixime for common throat infections and all. Rarely I would advise azithromycin, because I feel cefixime is very commonly used, and most of the time throat infections are uh, originating from viral exposure than bacterial. If there is tonsillitis, or if you can see pus inside mouth, then those cases I advise cefuroxime and augmentin at times. These are the common practices. And then, depending upon the culture reports in UTI, I would prefer to do UTI test. And for UTI, you also have to give treatment for symptoms like pain, burning, micturition, and things like that. For liver abscess, always, when it is liver abscess is liquefied, you have to drain it, and when it is not liquefied, antibiotic coverage has to be given. And amoebic liver abscess is common, so metronidazole is given in double dose. For urine infection, it is very challenging because most of the antibiotics that are used in uh, outpatient basis are resistant, common because of the uh, uh, frequent antibiotic use, and even over-the-counter purchase of antibiotics and sales by pharmacies. So, what often you would see and find uh, that nitrofurantoin is, old antibiotics are still responsive to such patients. Or even I've seen, moderately resistant, and still such antibiotics work if you give it for longer duration, because if you have no choice. Mostly for UTI, enteric fever, if you give injectables at your clinic, then ceftriaxone and amikacin kind of combination, provided there is no contraindication, you can uh, give, or you can give oral substitutes alternatively. And when there is patient is immunocompromised, or and there are other issues, abscess in, suppose, brain, chest, abdominal cavity, and those things should be referred, and we better be treated at hospitals with advanced or modalities. So this is the common approach, and as I said, if you've experienced, most of the fevers that come to our clinics are curable. And this is what I say. I mean, it is better to become feverologist, because everybody has a fever problem. Everybody will say fever, and there's no specific doctor for fever. Yes, we have infectious diseases doctor, but family physicians should be expert in dealing with the fever. So with experience, we all learn what would be the course of illness, how many days it will persist, what type of fever it is, all from history, presentation, examination, without even going for any tests. So we can treat most of the fever cases that come to our clinic, and rarely, if there are issues, if there are challenges in diagnosis, if patients do not subside, it is better to refer them to higher center, and you can do some test by yourself also, so that you know the cause of it, and then you can properly counsel and guide the patients. And rehydration is very, very important because patients should be hydrated, especially if there is gastrointestinal infections. And and many times discontinuation of medications, the few I discussed just before, drug-induced fevers, is this is a I just talk empirical antibiotic therapies. So as I said, if there is some specific throat infection or some urine symptoms, I would always give some antibiotics because I know it is UTI, it is bacterial, and it is always better to give empirical antibiotic. Otherwise, patient will not feel relief just with painkillers or fever antibiotic medicines. So similarly, when you know the cause, liver abscess, you have to treat accordingly. When you know tuberculosis, you have to give ATT. And but do use cefixime commonly for any suspected cause of fever. It covers long term, even if it turns out to be enteric later on. We do talk about antibiotic stewardship as well as appropriate use of antibiotics. So I do not experiment with many types of antibiotics. I would normally use cefixime, augmentin, or cefuroxime, and these are my commonest antibiotics. And most of the I nowadays never use even azithromycin for my patients or for routine use. I'll stick to the common antibiotics that I use for my patients and not use a variety of antibiotics, so that we do not put patients risk on exposing them to a number of antibiotics unnecessarily. So it is always be useful to give judicious antibiotic types of these are the medicine. Many times patient fever does not subside on 500 mg of paracetamol, then 650 mg higher dose, even 1 gram paracetamol is used, and in IV fluids also. Additionally, sometimes with a combination with uh, uh, other even sometimes combiflam like ibugesic, ibuprofen and paracetamol combination. These are useful, but mostly patients, it is wise to ask them to do sponging with with cloth which is dipped in water, and then you remove all water and then put it on body and keep on changing for half an hour to 1 hour. And it is common practice that people put some wet cloth on head or some iced cloth or handkerchief on forehead, which is not always useful. And sponging should be done all over body, chest, abdomen, legs, back, and then only fever subsides. So when my fever patients, and if it is not a very chilly and cold night, I would advise always for sponging rather than to increase some dose of paracetamol. So thank you. This is all approach to fever.